Welcome to the Mostly PT podcast. I'm Brad Bulmer.
I'm Alex Bretzman.
And today's episode is sponsored by Premium Towels. Strong, thick, and absorbent.
For all your absorbing needs.
19th episode.
Welcome back, 19. It's one away from 20.
We're going to get right into it today.
Rocking and rolling.
Board questions.
Practice NPTE board questions. We have 3 of them. Since it's the 3rd day of February and there's only 3 for this month.
Correct.
That's all as far as I want to go back.
That makes sense.
Question number 1. If it'll load for me. It is a category, other systems.
Okay.
Level basic. 88% of people got this correct.
Including Brand.
Question number 1. A patient is unable to take an adequate supply of nutrients by mouth. As a result, the patient's physician orders the implementation of tube feeding. What type of tube is most commonly used for short-term feeding?
Nasogastric?
Correct. Good job.
Good start. Good
That's
start.
That's one I was confident Brandon was going to get. Do you want to hear the answers?
Bark.
Or you're confident on that one?
Nah, we're good.
All right. Question number 2. Category, non-systems. Difficulty level, basic. 82% of people got this correct.
A little less.
This one was, I think, the trickiest one of the 3. A physical therapist directs a physical therapist assistant to measure the seat depth for a patient as part of an assessment for an appropriate fit of a wheelchair. How many inches should the therapist subtract from the standard measurement taken for wheelchair depth? 1, 2, 4, or 6?
How many inches?
How many inches should the therapist subtract from the standard measurement taken from wheelchair depth?
1, 2, 4, 6.
1, 2, 4, 6.
4.
Final answer?
Yeah.
Incorrect. It's 2 inches.
It's 2 inches?
Yeah. It's where you don't want the seat in their popliteal fold. So you want 2 inches of space there.
I'd prefer 4.
Yeah, a little bit extra room. That's one I thought would be tricky because
If they want to slouch, you know?
I had acute care last semester, so that's why I remember that one.
That's a stupid question, but relevant.
It's a relevant question.
If you're into...
Question number 3. Category, non-systems. Difficulty level, intermediate.
Ooh.
60% of people got this correct. Here's the question. A patient begins to cry in the middle of a treatment session. The physical therapist attempts to comfort... Would you take this seriously? Come on, man. A patient
start laughing.
A patient begins to cry in the middle of a treatment session. The physical therapist attempts to comfort the patient, however, eventually has to discontinue the treatment. What section of the SOAP note would be the most appropriate to document the incident? Subjective, objective, assessment, or plan?
So you're
the
putting...
incident is
The incident is them crying?
The incident is they have to discontinue the treatment.
Okay. I think there's 2 ways to think of this. What would Brant do, and what's the right answer?
But can they both be the same answer?
Yeah.
That's the question America wants.
Okay, well,
The
I'm
physical-
not going to put it in the subjective.
Okay.
I'm not going to put it in the assessment.
So that's
Treatment.
objective or plan?
Oh. Objective.
Incorrect.
Really? Subjective?
It's assessment. You're assessing the discontinuation.
Why would it not, if it's in the assessment, why would you not put it in the objective first?
The inability
If
to
anything,
continue,
it's going to be in the objective and the assessment.
you could argue subjective.
I would
because-
argue.
Yeah, but you said objective. You were over. You picked like the third.
My first
best
answer was objective.
That's the wrong answer.
Then how can it be in the assessment?
An inability to continue treatment due to a patient's emotional state should be documented in the assessment section of a SOAP note. This type of entry serves to justify the decision to terminate the treatment.
Well, it looks like I should work on that in therapy.
Brant went 1 for 3. Tough start.
Yeah.
I went 3 for 3, by the way.
Good
So
for you.
I just thought everyone should know that. You know what? It's okay. Let's move on.
That's fine. I would argue the... Never mind. All right. Would you rather? It's a good one. Would you rather be half your height or double your weight? Let me hear your answer first.
Here's the problem.
This is a lose-lose situation. Well, usually they are.
It's like, be so short that, like, humanity is like not set up for you.
Yeah.
Like everything here is for people that are of adequate height or height.
I don't know if I would say adequate.
Not adequate. Normal human
Yeah.
arms. But if you're double your weight right now, like the increased cardiovascular, like you're gonna probably die early.
You would if you were half your height.
So
too.
it
You
may,
would if you were half your height too. I'm pretty sure that's the thing.
yeah, you might be. So okay, so that'd be what? Let's do
What's the
that.
correct term? Little person?
2'11"? No, not little person.
It's not. They don't. What did you guys learn?
I don't know. I don't remember.
Pretty sure it is.
I don't think we ever covered it.
I'm pretty sure it's little person, not midget.
It's not. It's not.
Little person, I believe.
Okay.
Besides the point.
So
It's okay. Don't get.
two. I'm trying to think of my height. I'm trying to do the math. 2'11".
Cute little Alex.
2'11" or be 390 pounds. Almost pushing 4 bills at 5'10".
Yeah.
That would I wouldn't be able to move. We've done.
You'd be able to move. Well, you're staying the same height. Yeah, you would. I'm going half my height.
I think you have to. I think
See what
if
you did there?
If have
Yeah.
have words English. Yeah, I think
You're agreeing with me?
Yeah, I'm going half height. Because if you go double your weight, it would just be so uncomfortable to live, you know? Like,
Yeah.
400 pounds and be in your height right now, you would be so big that.
I don't weigh 200.
Roughly. 360? I'm sorry. You're not fat. You what weight now? 180?
Yeah, 180.
Okay, so 360.
He's good at math.
You're 40 pounds off 4 bills. Like, that's just.
Yeah. I feel like, if I'm half my height, right, and I'm thinking about how would this affect my life, I'm sure I could meet some people that I'd want to hang out with that are like me, compared to maybe.
Yeah, no, you could make being half your height work, I think. But if you were 5.
You know what? There's a counter that's pretty high. Jump.
For being severely overweight is, I think, much harder than being short.
It's weird that we agreed. It's not as.
It only took 19 episodes for Brent and I to agree on a would you rather. We better shake hands after that.
Thank you, brother.
Good work.
Moving on. This might be a quick one, folks.
we run out of stuff to talk about. This one should be good.
You got it.
If you could choose any cartoon character to be, like, do you want to say live like their life for a day, or like just be able to go in and out of if you could,
It's the same thing.
if you could be any cartoon character for however long you wanted to be, who would you be? But the thing is, it has to be an animated cartoon. Can't be like, well, I don't know, what cartoons aren't animated?
Non-animated?
I don't know. Yeah, animated
Right now.
cartoon.
You can't be in
It can't be in real life. It's an animated cartoon. I have my answer. Do you have your answer?
Yeah, you go.
We talked about it a little bit on the Halloween episode, but I would be Ben 10.
Why?
Because that was I was uber obsessed with that show for a year and a half, 2 years of my life when I was 8. Maybe a little younger than that, 6.
You technically get 10 characters.
Well, if you watch the
11.
show and know the lore, he gets more. And his Omnitrix, I believe the watch is called, evolves, and he gets different monsters and characters. But I played on Cartoon Network, on the gaming website, I would play all the Ben 10 games. I'm like, this is the coolest thing ever.
You were kind of a nerd.
A little bit. I had a Ben 10, the actual watch.
Yeah.
And I could flip through it or whatever, and I'd smack it and make noise, and I'm like, I can't remember the dude's name.
What noise would it make?
A transformation noise. He was like a Mighty Morphin Power Rangers kind of thing.
Okay.
Like metamorphic rock. That's how my 5th grade science professor taught me about metamorphic rock.
Yeah.
It changes under pressure.
Yeah, I know.
The Mighty Morphin Power Rangers.
Okay.
Morph, change, transform. Transformers. But yeah, Ben 10. I think that'd be kind of cool. What do you got?
I would be Winnie the Pooh.
Why? Why would you be Winnie the Pooh? That doesn't make any sense.
Well, let me explain.
What's your clinical reasoning for picking Winnie the Pooh?
There's a few. For one, it was my favorite cartoon growing up because it's basically the only thing I could watch was Winnie the Pooh. It was one of the few things I could watch. Two, I feel like Winnie the Pooh, he's just a really great guy. Like he had no cares in the world if you really think about it. All right, you know how empathetic he was.
Yeah, he's a really sincere guy.
Piglet would come over and just start crying, and Winnie the Pooh would be like, "It's okay."
He was definitely
give him some honey.
But not
her. I don't know if Piglet was a girl or a guy.
I think Piglet was a boy. What about like Tigger or Eeyore?
Yeah.
Why? So just Winnie the Pooh because Winnie the Pooh?
I just explained it.
Okay.
His personality.
Are you a honey guy? You like honey?
Not really.
Well, that's what he eats.
Yeah, I mean,
like I can see
honey.
I can see your argument being Winnie the Pooh because I want to eat cartoon honey. But if you don't you just want to be Winnie the Pooh just to
because he didn't have any cares in the world for one. It seemed like he didn't have any problems. Now
he doesn't have any cares in the world.
Maybe that was him coping with things that were going on. I don't.
He didn't have any cares in the world because he's not real.
Okay, well we're not trying to solve the Winnie the Pooh's problems, right? Holy buckets! I'm just saying I want to be Winnie the Pooh. All right, I want to. Yes, eat honey. He doesn't have to worry about what should I eat today. Honey. Doesn't have to decide on anything. Just eats honey. It tastes good.
He does have a pretty rockin' life. I'll give you that.
He's always happy. When was Winnie the Pooh sad? Never.
But
never once.
Ben 10 gets to fight just aliens. It's kind of cool.
Yeah, but Ben 10 probably had some aggressive issues. Like he probably had anger issues.
I don't know if he had anger issues. Some of the characters he probably chose to be had anger issues.
When his mom's like, "Hey, it's time for bed." No,
he didn't have a mom. It was his yeah, it was his sister Gwen and.
What happened to his mom?
I don't know. Him and his sister didn't have parents in the show. It was Uncle.
That's not how life works. You can't just appear and.
Huh?
How he had no parents?
Well, they weren't in the show. They never. I don't know if they ever talked about that. I was 7. I just know he had Uncle Ben.
Those are the questions that I would ask if I was 7.
Well, I'd ask why.
How did Ben 10 become into the world? Like, did his parents?
I don't know. Probably through how everyone else comes in the world. Birth.
Well, it's a cartoon, so
X and Y chromosome.
All right,
I went like this, but
that's how kids are made.
Oh dear Lord.
All right. PT topic of the day.
Because we are a mostly PT podcast, so let's talk mostly PT.
Neck pain.
Neck pain.
And why are we talking about this? Alex has a test coming up.
I guess that's really the only reason we're talking about it. It's the second most severe thing that costs the U.S. money besides back pain for MSK problems.
I believe it.
So low back pain is number 1 and neck pain's 2.
Would you consider shoulder pain in the neck pain
if it was referred, yeah?
Yeah.
But
I wonder how they determine that, like
for like cost models and stuff.
Yeah.
Like how much money are you spending on shoulder-related pain or shoulder-related pain coming from the neck?
Yeah, because that's very. I feel like it's subjective to say.
There's one guy's job behind a desk to sit there and sort out everything and then do all the math. That's one guy that's putting out those studies with like probably the CDC.
He might have neck pain.
He probably has neck pain.
Puts himself in there.
Little kyphotic posture.
Okay.
And more thoracic, but.
So specifically, what we're going to be talking about is a CPG, clinical practice guideline.
What is a clinical practice guideline used for, Brent?
Clinical practice, and it's a guideline. I feel like those are.
Okay, explain the word clinical practice guideline without using the word clinical practice or guideline.
It's a tool that therapists can use. Pretty general statements about what's based off the evidence. So it summarizes a ton of evidence. And while also using like experienced clinicians or researchers, their opinion, because that's also in CPGs.
Yep.
And it encompasses all of that, and it's pretty long kind of list of things.
They're terribly long to read.
Yeah, I just skip to the. Well, I usually try to find like a summary.
Yeah.
But
CPGs are.
I'm not a huge CPG person.
Not a huge CPG.
But I feel like they can be used. Like it's a good I don't really know what to do, start there kind of thing.
Brandt's right. CPGs, big tool. They take a bunch of research articles, they combine them together, and they say what you should do to treat a patient. And they are considered the highest level of evidence in the medical world, at least in the physical therapy world. I don't know they have CPGs for other things? They have
I'm
to, right?
assuming.
Like
Yeah.
for surgery?
Probably. I don't know actually.
We should look that up.
I don't have my phone. Whatever.
We'll figure it out later.
Okay.
CPG for
what?
neck pain.
Okay, yeah, for neck pain. So, a CPG, let's say, for example, with the neck, it's going to break it down into a few different presentations. So, Alex, what are they?
I don't know. You're supposed to say this.
Okay. Neck pain. So,
Neck pain with
you have a
mobility
patient come in.
deficits.
You have a patient come in, and it's like, what group do they fall under? Okay? First one, neck pain with mobility deficits. What does that mean? You can't move your neck very well.
You have pain, and it's caused by mobility deficits, or causing mobility deficits.
Or associated. I don't know if I would say cause.
Correlated.
Yeah. Okay. Second one, neck pain with cervicogenic dizziness
Or headaches.
or headaches. You mind explaining all of these?
Cervicogenic headaches are headaches that stem from the actual cervical spine and the irritation that's in there, and that's what flares up. You actually get headaches, and they're usually unilaterally, and they're pretty easy to treat.
Really?
Yeah. Get
You
some
treated
snacks.
one? You treated one?
We talked about it on Thursday, I think. We had a case study to do on it.
In class they say they're pretty easy to treat.
Yeah.
Alex, they're really easy to treat.
They're not. Every patient is different. Every different patient has different complexity levels and stuff like that. But the general rule is cervicogenic headaches usually respond pretty well to physical therapy treatment and conservative treatment.
They do. Just based off experience. I've had a few.
Using the biopsychosocial model, we can use that to help predict patient outcomes.
Okay, great statement. Okay, what about like the dizziness? How does that present? How do you determine what is it dizziness from orthostatic hypotension? Is it dizziness from other things?
Well, you probably start with the systems review and take vitals and stuff like that. Ask about medical history.
I'm saying, what are the main things you're looking for cervicogenic dizziness?
Oh, cervicogenic dizziness, the cluster is what I would probably be looking
What's
for.
the cluster?
It is pain from OA to C4, limited cervical extension, and decreased deep neck flexor strength. So the norms are 29 seconds for females, 38 seconds for males.
One of them isn't like rotating or neck motions bring on dizziness?
It's the extension.
Brings
And
on symptoms?
Yeah.
Oh, okay. Okay. So I think the main thing you're looking at is, does neck motion bring on their dizziness?
Yep.
Okay. Is their dizziness, are they always dizzy, or does it come and go? I feel like that's a big one to determine what's causing it.
Do they have aura with it? Is it associated with any?
They got aura.
They got big aura. Is it associated with is it just that their neck's causing it, or is it more of a contextual factor, stress thing? Is it, maybe some medications that they're taking that they're noticing? As soon as they take their medication, 30 minutes later, they're having this headache. Is it just because they feel like their posture's bad or something like that, along the lines of that? So it could be multifactorial, but cervicogenic headaches, looking at the cluster, see if they fall into that. It has like a 100% sensitivity ratio and a 94% specificity ratio.
Pretty good.
Pretty high.
Okay. Neck pain with movement coordination deficits.
Usually whiplash.
How would I explain this? You can move a lot at the neck.
This is where whiplash falls under.
Yeah.
Yeah.
So you're very mobile in the neck. Usually people are saying, hey, I need to crack my neck all the time because it feels like it's just like really, it feels stiff, but it's not.
It just needs to go.
I don't know if people say that.
Well, it just feels like it needs to go. You've never heard of that before?
Let me rip off my neck.
Have you ever had a stiff back and you're like, it feels like it
needs to
It
crack.
needs to go.
Alright, yeah. Okay.
I guess different
Needs
terminology.
to go. Where's it going?
Like crack.
Oh, okay.
I'm not saying, no, it needs to move.
Take out my back.
Yeah, it needs to go.
Sorry,
Get it out
I'm
of
finding
here.
it really funny, but it shouldn't be.
It's just a terminology, I guess. You've never heard someone say that? It feels like it just needs to go?
No.
Ugh.
Okay. And finally, neck pain with radicular pain.
What's the difference between radicular pain and radiculopathy, Brant?
Radiculopathy, you're going to have neurological deficits. You're going to have strength deficits, reflex changes. Difference in dermatomes wouldn't be that relative, I feel like, unless you're completely numb. Biggest thing I'm looking for is strength and reflexes.
Yeah, dermatomyontonal changes is what we're taught, but yeah, you're correct.
I'm just saying, it's if someone just has numbness or tingling, I'm not just gonna say they have radiculopathy.
Right, there has to be other. What if it's a sensory nerve that's impaired? It's more likely to be just dermatomal, and if it's a motor nerve that's impaired, it's more likely to be actual muscle.
If it's just a cutaneous nerve, I'm probably not gonna refer them out. So that's why I wouldn't be that worried about it.
It's cluster for radiating pain too.
Really?
Mm-hmm.
Oh, isn't that the radicular?
Yeah.
What's the cluster?
Oh, Cody sign.
Yeah,
Positive median nerve.
I've seen that actually.
Or pain with rotation less than 60 degrees to the involved side, and Sperling's and distraction. I don't think
Did
Bacotti
you
sign.
say median nerve tension
Yeah,
test?
type 1. Or I don't think Bacotti sign is actually in there. It's Sperling's distraction, median nerve, and less than 60 degrees of rotation at the involved side.
Okay.
I think those are the 4.
All right.
Bacotti sign isn't part of the cluster, but it is a way that you can help differentiate between radicular pain.
What do you want to delve into? We've kind of explained all the different presentations that you might see.
How about some treatments? How about some manipulations?
Okay.
Hot topic. Not really hot topic, but here's the thing. I'm going to talk about manipulations for a little bit. I didn't ever think that they would be like as... What are you... Just getting comfortable? Get comfortable. I didn't think like cervical manipulations, thoracic manipulations, stuff like that, cracking your neck, cracking your back, would actually be of like clinical significance in use. Like practicality. Like I thought they were just tools being like, hey, I've got my neck cracked before. That's something you do? And you're like, yeah, I've actually been taught it or whatever. But there's actually very good research that shows that cervical manipulations and thoracic manipulations help with neck pain. So that's something I found kind of interesting. And that's basically all we're doing right now in class. And so I've been practicing cracking necks left and right. I think I'm pretty good. I'm okay. I need more practice. But I think I've got a good foundation with like my arthrokinematics, my high velocity, low amplitude movements, mid-range manipulations.
Would you give a cervical manip an initial eval? There's no right answer.
If I ran through all like the cranial nerve exam, upper quarter screen, and I found that they met the clinical prediction rule that it was going to be beneficial, and I found no red flags that would stop from doing it, yeah. Hold them in the pre-hold position, check their eyes out, 10 seconds, how you doing, stuff like that.
Okay.
If I went through all the necessary precautions to do it, and I found that it was going to be beneficial for the patient, yeah. Would I do it with, like that's like probably the 1% of people that come in, like doing it day one, I think. But I think it would be something beneficial for more people later on in treatment, probably on day one. How often do you manip in the clinic?
I think I've done a thoracic manip a few times. Cervical manip probably a couple times. Not very often.
Yeah, like I said.
Could I do it more? Probably.
Yeah. I think that's it. I've only, like on my last clinical, I saw it twice, 3 times maybe.
Yeah.
Like I'm saying all this stuff like, oh yeah, it's really beneficial. There's a lot of research behind it. And there's a higher level of practicality than I thought. But that went from like never seeing it all to like 2 times in 6 weeks.
Yeah.
So that's really where, I mean, you gotta kind of hone in on what you're treating.
Yeah.
And not a lot of people, you're not gonna cervical manip someone that has knee pain, you know.
I mean,
for the neurophysiological effects.
Besides the point. What's the risk with a little neck crack? Like how risky is it?
I believe it's 1 in 1 million to develop an adverse reaction.
You are more likely to die from ibuprofen, I believe.
You're more likely to get a GI bleed from ibuprofen.
Or GI bleed. GI? What? How is it GI bleed? What?
Gastrointestinal.
No, I know. I'm saying, but you're not going to get that from a neck crack. That's what.
No, you're more likely to get a GI bleed from ibuprofen than get an adverse effect.
Okay, I see.
From a nip.
Does
that make sense?
I thought you were saying you're more likely to get a GI bleed from taking ibuprofen than a neck manipulation.
My CI
No
said,
crap.
My CI said you're more likely to get hurt walking on a treadmill than to get hurt during a cervical manipulation.
Sure, you.
Everyone's worried about the vertebral artery, and you place more pressure on the vertebral artery during range of motion movements than the actual manip itself, which I was like astounded
I
by.
mean, that makes sense because
I was like, no, that's crazy. I couldn't fathom that for a couple minutes. I'm like, really? Wow, that's nuts.
well, because you're not even at end range when you're doing a manipulation.
I guess that makes sense. Yeah, if you stay in mid range and you're not really pressing, or you're not putting any
That's
pressure.
probably why
on the
they
artery.
teach it in mid range.
And then when the adverse effects do occur, it's likely due to there was already something wrong and they didn't go through the screen prior to manipulating someone.
Yeah.
Very, very, very unlikely you're going to get a dissection of the vertebral artery during a cervical manipulation.
There's one point. I feel like I have to bring up one point though. Like, yes, the risk is very low, but like compared to other risks with exercises, I feel like it's pretty high. Like what can happen if it were to happen? Like, yes, very low risk, but that risk, like what you would get, is very serious compared to like I'm gonna have someone do some ankle mobility.
Fair.
It's not.
Yeah, it is of the higher risk compared to doing PROM of the knee. But think of it this way: like if you're going to bench, you probably it's probably the same outcome if like it's say the circumstances are under normal. Like you're probably the same percentage to tear a pec while bench pressing, while to get
Then doing a neck manipulation.
to get it. No, you're not going to tear a pec during a neck manipulation. I'm trying to compare and contrast two things
I know,
happening.
but I feel like you're doing it weird in a weird way.
You're probably the same like
Comparing two different things, but yeah, I get it. You're more likely to tear a pec benching than you are for the repercussions with a neck manipulation.
Right. Don't crack your neck. Don't crack your own neck either.
Why?
Because I will. Okay, well, there you go. This is not medical advice. As you crack, was that your fingers or was that your neck? Wow.
Yeah. Get some ASMR.
I can't even do that.
Yeah, well, you're not a therapist.
I guess not. I'll be able to do it in a year and a half. That was crazy.
Yeah. We will see you next time.
This has been the Mostly PT Podcast.